Swayam Prabha. Digital India. Educated India.
As medical doctors, we are used to see the patients and diagnose the condition and then offer treatment or manage the patients. What we are going to discuss today is diagnosing the condition in the baby before the birth of the baby, when the baby is in the mother's womb. So, that is what we call prenatal diagnosis. Most of my talk will be on genetic disorders. Some are birth defects which may not be genetic, but you will see later how birth defects and genetic conditions are diagnosed in the mother's womb before the baby is born, what we call prenatal diagnosis. If you see conceptions, everybody wishes to have normal baby at the end of 9 months, but this does not happen so in some of the situations. And if you see 1 in 8, sometimes we say 1 in 6 pregnancies end up in abortions, and 1 in 50, that is 2 to 3% of the births have a major congenital abnormality, and some of the pregnancies or babies are affected with single gene disorders. We call them Mendelian disorders or monogenic disorders. Major chromosomal abnormality can be present in 1 in 200, and some pregnancies end up in stillbirths or perinatal deaths, which are not usually the desired outcomes of a healthy conception. Now, let us discuss what are the goals of prenatal diagnosis. Why should we detect a genetic disease or a birth defect or a disease in the baby before the baby is born? The ultimate wish or the desire of a medical field is to treat the baby if there is some problem, or we call it fetal therapy. The major goal is to have a healthy baby at the end of 9 months of pregnancy by treating the genetic defects if they can be identified in utero. And then second is better management of pregnancy and delivery. So, you can take the mother to a good tertiary care center for delivery and take care of the pregnancy better, and the baby is treated immediately after the birth. So, that is one of the advantages of knowing that a baby is going to be delivered with a genetic disorder or a birth defect. Now, if there is some conditions like congenital diaphragmatic hernia, we need a good pediatric surgeon, a good neonatal care where surgery can be done and managed better and the outcome can be improved. That is one more indication. Unfortunately, several disorders do not have any treatment, and we end up in offering termination of pregnancies where fetus is severely affected or they may not have a useful and productive life. And sometimes the pregnancy may end up being aborted, but will it recur? Will it happen again in the subsequent pregnancy? That can also be known by prenatal diagnosis. So, this slide summarizes why do we do prenatal diagnosis for pregnancies. When do we do prenatal diagnosis? That is what we are discussing under the heading of indications for prenatal diagnosis. So, every mother or prospective mother wants to know whether the baby is going to be healthy or not. So, we need to classify them as low risk population, means any pregnant women, or high risk population, which I will be discussing in my next slide, who are high risk. So, any pregnant women should be offered some basic prenatal testing methods, which includes an ultrasonography to detect major fetal malformations, and screening for aneuploidy or chromosomal disorders like Down syndrome, trisomy 13, trisomy 18, and a neural tube defect, which is so common, affecting 1 in 1000 pregnancies, or it may be a person who, because of his ethnicity, predisposed to certain genetic disorders, for example, thalassemia, which is highly prevalent in India, or a Jew where the Tay-Sachs disease is very common, or a Caucasian where cystic fibrosis is very common. So, depending on ethnicity, we might have different indications in different populations for certain disease. So, I am talking about the low risk who does not have any other reason for prenatal diagnosis. There are some basic list of tests or prenatal diagnostic methods which we do for detection of the genetic problems. In high risk population, when we say high risk, it is actually those who have more than normal risk as compared to the general population of a certain genetic disorder or birth defect. These include chromosomal disorders like previous child having a Down syndrome or chromosomal problem, single gene disorders. It can be thalassemia, sickle cell disease, hemophilia, spinal muscular atrophy, Duchenne muscular dystrophy and so on. And malformations, some may be at higher risk of malformation, for example, previous child with malformation or parents having some malformations, and sometimes it can be non-genetic indications like immune high drops, where we get high drops in the fetus because of blood group incompatibility, and then intrauterine infections or teratogenic exposure. Some pregnant women, without knowing they are pregnant or without knowing that the drugs can have certain adverse reactions, they take the medicine and we want to test whether the fetus is affected or not. Or it can be maternal disease like diabetes mellitus, epilepsy or rheumatoid arthritis, SLE and so on, where fetus is at risk of certain disease, which all come under the category of high risk population or high risk pregnancy, where fetus is at higher risk than the normal or general population for a risk for a disease in the fetus. Prenatal diagnostic tests can be classified into two groups. One is invasive, another one is non-invasive. Invasive means we take samples from the fetus. Non-invasive would also mean, probably when we say non-invasive, it is non-invasive to the fetus. We may take maternal blood or we may do something like ultrasonography. So, we have few of them. One is ultrasonography, where we use ultrasound to detect fetal anomalies, or maternal screening, where we take samples from the mother in the first trimester or second trimester to see whether they are at risk of certain chromosomal abnormalities or neural tube defects and so on. And it can be something like which is picking up now in the recent days is non-invasive prenatal testing, where fetal DNA which escapes into the mother circulation is analyzed to see whether the fetus has risk of an aneuploidy like Down syndrome or trisomy 18, trisomy 13. More than that, we now have several artificial reproductive techniques where we have in vitro fertilization or test tube babies, what we call. We have the embryos outside or gametes outside, where we create embryos and we implant into the uterus. Before that, a cell can be taken and can be studied for chromosomal abnormalities or a certain genetic disease, where couple undergo in vitro fertilization. I will not be discussing pre-implantation genetic diagnosis further in my presentation today, but this is one of the important ways how abortions can be prevented, or before the embryo is implanted, you can test the fetus for a particular genetic problem, which can be chromosomal or non-chromosomal. Now, with the advent of high resolution ultrasonography, you can see here, you can see the face of the fetus so well. You can see the nostrils, mouth, lips, and even the nose, chin, as you see in the right top corner of the image on this screen, or you can see the ears on the right lower corner, how ears can be studied. A good ultrasound machine with or with the probe with an expert ultrasonographer can detect most of the major congenital malformations. But remember, we cannot assess the function of brain muscles by ultrasonography. I will give you few examples here. You have in the left upper corner, you have cystic hygroma, where you have some fluid collection behind the neck, which can indicate high drops, which can indicate chromosomal abnormality, which can indicate cardiac abnormality, which can indicate fetal infections. Or below you can see the enlarged cystic space behind the cerebellum, or right upper corner you can see bilateral cystic kidneys, or below you see double bubble sign, which suggests there is duodenal atresia and the fetus may be at risk of Down syndrome. So, this is how Structural abnormalities can be detected prenatally by ultrasonography. Coming to maternal screening, where this is another method of non-invasive testing, it can be done by in the first trimester if they come early, which is actually ideal, or somebody coming late, second trimester, or non-invasive prenatal screening. So, first trimester involves measuring nuchal translucency, beta HCG and pregnancy associated plasma protein A, and this is probably the best available screening test after NIPS. In the second trimester, we used to do triple test, now it is quadruple test. Triple test no longer has a place in screening, and especially if somebody comes in the first trimester, you have first trimester screening, which can detect up to 90 to 95% of the pregnancies affected with Down syndrome. The sensitivity decreases for second trimester screening methods, and NIPS is probably the one which has highest sensitivity, which can be done from the fetal DNA circulating in the mother's blood from 10-week onwards, which is currently expensive, but probably has the highest sensitivity and detection rate. In general, all the professional societies recommend that all pregnant women should be offered screening for common chromosomal aneuploidies like trisomy 21, 13 and 18, irrespective of the maternal age. I will now discuss invasive prenatal testing. We have discussed ultrasonography and maternal screening, which includes non-invasive prenatal screening from mother's blood as non-invasive testing. Invasive testing involves taking samples from the fetus either by chorionic sampling, amniocentesis, fetal blood sampling or fetal tissue sampling. One by one I will discuss in my slides. When do we do invasive testing? It may be to study the chromosomes in the fetus. For example, advanced maternal age, when the expected date of when the age of the mother at the expected time of delivery is 35 or more, positive triple test, quadruple test or a screening test, previous child with a chromosomal anomaly, chromosomal rearrangement in a parent, fetal malformations or marker for aneuploidy by ultrasound or chromosomal breakage syndrome. You can study the chromosomes by taking fetal samples. This is karyotype showing abnormal chromosome 4 and abnormal chromosome 21 in a mother, which predisposes or which increases the risk of baby having a chromosomal problem. So, this is one of the indications for prenatal testing. We can now detect chromosomal aneuploidy. When I say aneuploidy, most of the times it is Down syndrome or trisomy 21, but it can also be 13 chromosome 13 aneuploidy in the form of trisomy 13 or trisomy 18, which can be extended to all the chromosomes now with newer techniques. We can traditionally we used to wait for 2 to 3 weeks for the karyotype results to be available, but if you are specifically looking for 1 or 2 chromosomes, we can do something like QF PCR or quantitative fluorescence PCR, where you can see here on the top panel we have 2 markers for chromosome 21, which is normal, and below you have 3 markers for trisomy 21, which suggests there is trisomy 21. Next reason for invasive testing is molecular diagnosis. We take fetal DNA and test for genetic disorders. As we all know now, we have approximately 18 to 19,000 genes, and we have nearly 3 to 5,000 monogenic disorders. In principle or in practice, we can test all of them in the fetuses by just taking DNA sample from the placenta or amniotic fluid, which is supposed to match with that of the fetus which is yet to be born. The most common indications I have listed here, which includes thalassemia, spinal muscular atrophy, Duchenne muscular dystrophy, hemophilia A and B, or as I said earlier, any monogenic disease with a known mutation. That is a prerequisite. We should have a diagnosis before what we are looking for in the sample of the baby, then we can do prenatal diagnosis. One example is Duchenne muscular dystrophy, where children have progressive muscle weakness, hypertrophy of the muscles, and then usually they succumb to death in their second decade. It can be done by several ways. I will give one example where it can be done by multiplex PCR. You can see the bands for different exons of DMD gene. I have written some negative control, patient, positive control, and you can see here on the right side in the lane 9, one band is missing. What we do is we take the DNA, we run the PCR, using different primers for the DMD gene, and a particular band is missing, that means that particular exon is deleted, and that is how we make the diagnosis of DMD. This is one of the ways. We have now MLPA, multiplex ligation dependent probe amplification, that can also be used. There are several techniques. This is using gel electrophoresis. We call this actually multiplex PCR, where we do several PCRs in one tube and detect whether the unborn baby has Duchenne muscular dystrophy. We do this test when the mother has either previous history of a son being affected with this condition, or brother affected with this condition, or maternal uncle, because you must be knowing this is an X-linked recessive condition. Most of the genetic testing on DNA is now done on by using Sanger sequencing. We have a Sanger sequencing shown in the picture, and we have sequence chromatogram. When we see the altered color, altered the chromatogram pattern, then we say what is normal, what is abnormal, and that is how we can detect a fetus which is affected versus a fetus which is unaffected. I have listed the techniques here, and when do we do? Chorionic villus sampling is done between 10 to 12 weeks actually, and amniocentesis 15 to 16 weeks or later, and fetal blood sampling usually is done after 20 weeks. Fetal skin, liver or muscle biopsy, the fetal blood sampling and fetal tissue sampling is rarely used nowadays, because we have earlier techniques like chorionic villus sampling and amniocentesis, and better we have molecular testing facilities which can be done as early as 11 weeks. So, we do not wait for fetal blood sampling, that is usually reserved for people who come later in gestation. Any skin, liver, muscle biopsy, again the indications are becoming lesser, because these can be studied by taking the fetal DNA through chorionic villus sampling or amniocentesis. Before you do the test, we need to have some list of things to do. We have actually. So, one most important is genetic counseling. People should know what is the test being done, why it is being done, before the test and after the test, what are the, I will give you the list of things which we discussed during genetic counseling in my subsequent slide, and a correct diagnosis or correct indication should be established. If you do not know what you need to look for, you will not be able to do the test. So, we need to identify what is the genetic problem in the family beforehand, unless it is something like Down syndrome, where we know it is chromosome 21 which is increased in number. Otherwise, for monogenic diseases, or even for that matter, we need to know what is that what we are looking for. We do not have a test which can look at all the diseases in one test. So, usually it is specific test for specific genetic condition, and we should have a definitive diagnosis in the proband which is not doubtful, because if we do not have a perfect diagnosis in the proband or for the first affected person, we may not be able to test. We need in return informed consent, where we explain the procedure to the patient and the family, and then we take written consent, and trained laboratory personnel. A good lab is important. Okay. The lab should be reliable, and they should have trained people to do the test, and we should follow the local ethical and legal consideration, especially we are going to handle a human life, because somebody may not wish to continue the pregnancy if the baby is affected. So, the local law or the ethical standards should be followed before we offer prenatal testing. I am just showing one example how before amniocentesis patients are given information. It should be ideally given in a written pamphlet for the patient, so that they read it very well, they take it home, they have ample time to read, ample time to ask questions to you if they have any doubts, so that they are answered before they undergo the particular test. Genetic counseling, what we do before the testing is genetic counseling. We tell what is the risk of abnormality, whether it is 25%, 50% or 1% or lower, or exact risk figure should be given if it is known, and explain the natural history. If you do not do the prenatal testing, what happens? What happens to the baby after birth? What is the natural history? What is the treatment option for the disease, and how do they respond? What is the response to treatment? And discuss selective termination if the condition is very serious, or treating after the baby is born or shifting to a place where the facilities are available. Discuss the procedure in detail. What is the risk to the fetus? Is there any risk to the mother, which is usually not there, but with good centers, good trained people, good machines, the risk to the fetus and mother have come down drastically to the extent of 1 in 1000 for amniocentesis, 1 in 500 for chorionic villus sampling. What is the failure rate? A person or a doctor may fail to get the sample due to various reasons. What is the cost? What is the laboratory test we are going to do? What is the error rate? What is the limitation? Whether it tests one disease, two diseases or many diseases, or what we have targeted. So, these things should be explained to the family before we do the procedure. In India, we have a PCPNDT Act, Preconception Prenatal Diagnosis Act, which requires all the persons involved to declare what test they are going to do, what is the who is the person who is undergoing the test, what is the indication, do they have living children, how many children they have. Basically, this is done to prevent female feticides. So, we need to declare that female the gender of the fetus is not determined or not revealed, and then we have some Medical Termination of Pregnancies Act, which says it is illegal to terminate pregnancies after 20 weeks of gestation, and actually after 12 weeks without two medical opinions, but after 20 weeks for any reason. So, these are the two laws which we need to remember before doing the prenatal diagnosis, and it should be explained to the family. Before the procedure, we take the blood group. If somebody is Rh negative, we give anti-D immunoglobulins to prevent Rh isoimmunization. We take consent, we fill PCPNDT forms as per the law. Some centers give antibiotics, some do not, but the institutional practice should be followed. Anomaly scan should be done before the procedure whenever possible. Localize the placenta, see the baby is alive, you do not test a pregnancy when the fetus is not active or there is no fetal heart activity, and determine the site how you are going to do. In the next slide, I am going to show how amniocentesis looks from outside. You can see the abdomen is cleaned and wrapped under aseptic precautions, and then a fine needle is passed through the abdomen of the pregnant lady to collect the fluid in a syringe, or which is then transferred to particular containers for transporting it to the lab. So, you can see how we do sampling. This is amniocentesis. You can see the amniotic fluid, clear amniotic fluid coming into the syringe, which is then sealed and labeled and then sent to the laboratory for further testing. You can see on the ultrasound monitor a needle entering through the abdominal wall of the lady into the uterine cavity. The black space is amniotic fluid, and you can see the needle entering, then amniotic fluid is withdrawn, and after the procedure it is taken back. So, amniocentesis is the most commonly used prenatal testing because it is easy and it is done between 15 to 20 or 22 weeks, and it is the safest and most suited for fetal karyotype. A good labs can do karyotyping from chorionic villi as well, but this is currently most commonly used test. I will now show chorionic villus sampling. You can see here a needle is, after cleaning the abdomen, needle is passed to the placenta. You can see the needle tip, that white dot, and then from few villi are aspirated through suction through the syringe, and villi come to the syringe, then you transfer it to a good container, and then you transport it to the lab. You can see this is 4 times magnification of the villi, finger like projections or grape like structures, almost actually finger like projections I would say, of the chorionic villi, which is from the placenta, and then this contains the same DNA as that of the fetus, which we further analyze. It is done at 11 to 12 weeks. So, it is early in pregnancy, probably the earliest test which we can do. Between 10 to 12 weeks gives good quantity of fetal DNA. When we take few villi, it contains usually more DNA than amniotic fluid, allows early detection of the disease and early termination before 12 to 13 weeks, and it is ideal for DNA testing and enzyme assay if you want to do. And if there is a good lab, they can do karyotyping. There may be sometimes mosaicism in the CVS, but which is not reflected in the fetus. So, this is one of the things which we need to keep in mind. We may get abnormal result in the CVS and it may not actually represent what is there in the fetus, but these are very rare situations. Now, I will show cordocentesis, which is used lesser and lesser nowadays, but this is how it is done under visualization from through the ultrasound machine. You pass the needle, you can see the white tip going in and then it enters the cord. I am going through the placenta, you can see the white tip. Sometimes you may have to reorient the direction of the needle, and once you enter the cord, you take 1 or 2 ml of blood sample. See, you can see that I just nicked the cord and took the blood sample. Usually it is used nowadays for intrauterine transfusion. Usually for people who present late in 20 weeks or later, it allows rapid karyotyping, because from blood you can do karyotyping quickly, because the cells multiply faster than chorionic villi or amniocytes. We can detect fetal infections, anemia, thrombocytopenia, thalassemia and hemophilia if no mutation is identified. This situation is very rare nowadays, because we identify mutations in most of them. This has higher fetal loss rate as compared to amniocentesis and chorionic villus sampling. After the procedure, see and show the fetal heartbeat to the mother or the lady to show that the procedure was safe, show the fetal activity, ask them to take rest for 2 to 3 hours and tell whether they have to take antibiotics, or if there is pain what should be done, and samples. After the procedure, just take care, samples are also very precious, they are transported safely with appropriate labeling without mixing of the samples from different patients, they are transported correctly to the lab. And how much time does it take to get the results, and when they should come for the report and post test counseling. We need to know, if we do not take precautions, there may be RH isoimmunization during the procedure. An RH negative lady can get immunized by a fetus who is RH positive. There may be very minimal risk of infection, amniotic fluid leak, bleeding, fetal loss rates. These are very rare, but you should inform the lady that these are rare complications. Just to summarize what we have discussed today, we have discussed prenatal diagnosis of genetic disorders. Most of the times these are the conditions, either for fetal malformations by ultrasound or non-invasive testing for almost all women by maternal serum screening or non-invasive prenatal screening using fetal DNA. Amniocentesis and chorionic villi are the most commonly used methods for invasive testing of the fetus. Most common condition tested is Down syndrome or single gene disorders like beta thalassemia, spinal muscular atrophy and Duchenne muscular dystrophy. These are the most common, but it may vary from place to place, from center to center. Thank you.